We're very happy to introduce an update from the first cohort of National NIH K12 DiabDocs Program Scholars Research. And this is, very exciting to us. We first spoke about this program in July 2022 with Dr. Linda DiMaglio and Dr. David Maas, the founders of the program. Just a little bit about the founders, a very short intro. They're both very well known in the field, but Dr. DiMaglio is the chief of the Riley Hospital for Children's Division of Pediatric Endocrinology and Diabetology. She directs local and national research teams focused on preventing type 1 diabetes, preserving beta cell function, and improving metabolic control and quality of life for persons living with the disease. And Dr. David Maas is a Lucille Salter-Packer Professor of Pediatrics and Division Chief of Pediatric Endocrinology at Stanford. And he earned his MD, followed by a pediatric residency in the University of New Mexico. They both have been champions of supporting, early career scientists, clinician scientists in the field. And we so appreciate them putting together this initiative. Just a little bit about these very talented fellows. I'll just go in order in how they're going to speak. Schafer Boeder MD is a board-certified endocrinologist. He diagnoses and treats people with a variety of endocrine disorders. He has a particular interest in diabetes, and he's a member of the inpatient glycemic control team, where he works with patients to monitor glucose levels and maintain long-term glucose control. He does not see patients at outpatient clinics, but he is currently available at Stanford. He's involved in training medical students, residents, and fellows. His research is focused on new medications, devices, and technologies to help patients with type 1 diabetes. Let's see, the next fellow is Dr. Charlotte Chen. She's a DO. She's an attending physician, pediatric endocrinology and diabetes at Children's Hospital in Montefiore. Her clinical focus is in improving biomedical and psychosocial outcomes in youth with chronic endocrinopathies. Sorry, I'm just trying to let people in as well as introduce you. A graduate of the New York Institute of Technology, then she received her Bachelor of Science from the Institute in 2012, followed by her Doctor of Osteopathy from the Institute's College of Osteopathic Medicine in 2016. And she completed her pediatrics fellowship at Robert Wood Johnson's Medical School and pursued a fellowship in pediatric endocrinology at Boston Children's. Her research focuses on advancing diabetes technology use and reducing health inequality for youth with type 1 diabetes. Dr. Jamie Felton is a board-certified pediatric endocrinologist at the Riley Hospital for Children and a physician scientist at IU, Indiana University Center for Diabetes, and Metabolic Diseases, and the Herman B. Wells Center for Pediatric Research. She earned her MD from the University of Texas before completing her pediatric residency at University of North Carolina in Chapel Hill. She completed her pediatric endocrinology fellowship at Vanderbilt, and she stayed for another year to do postdoctoral research with Dr. James Thomas, investigating the role of B lymphocytes in type 1 diabetes pathogenesis. She joined IU November 2018, and her research passions include understanding the immune pathogenesis of type 1 in order to develop effective therapeutic interventions. And last but not least, Dr. Zoe Quandt is an endocrinologist caring for patients who develop hormonal side effects from their cancer treatments, especially from immunotherapy. She is also leading efforts to expand treatment options for patients with early stage type 1 diabetes. She earned her medical degree at UCSF. She completed a residency at Stanford, followed by a fellowship in diabetes endocrinology and metabolism at UCSF. And I would like to say thank you very much for all four for joining. I've been trying to be a little brief on our bios, just because I want to save room for all this really exciting work that they are doing and will be sharing with us. So I just wanted to have a few, David and Linda, if you'd like to speak to this program a little bit.
Sure. No, thank you very much. And thanks for inviting our scholars. When David and I met with you, I think it was last year earlier this year to talk about the program on your podcast. It was, this was all kind of a visionary kind of endeavor. And we're so excited to have our first 11 scholars funded. So we have the 4 that are going to be here and speaking with us today. And then on the screen, you can see the next 7. So just a quick overview of the program, because I also don't want to take more time from the scholars, is just to note that our program is called DiabDocs. It's a national K12 training program. It's designed for mentored early career physician research training. Actually, it says there's still type 1 diabetes. We need to update that. It's now in all sorts of diabetes. So we have some funding now for type 2 and non-type 1. Our awards are designed to provide a diverse group of early career physician scientists the opportunity to be mentored in research intensive settings. People can stay at their home institutions. They can also move to do the program if they wish to, but they previously there were institutional K programs, and the programs have now been sunset in favor of this national program. And the research just simply has to be relevant to diabetes, but can be in any area of diabetes. And you'll hear about a diversity of work, as Monica, you outlined in the introduction, and the awards last 1 to 3 years. So if you have more questions about the program, Dave and I are going to be on during the podcast and are happy to answer questions. Komal Dasani, who's also our program administrator, is also, I saw her in the room, and she can help out as well. But if you've got any questions, email us or visit us or contact us, and we'll take questions. And David, anything else you want to add?
Linda, wonderful introduction. Monica, thank you so much for having us. And we're really looking forward to the 4 K12 scholars. We're very proud of all their work. And I think you're all going to be really excited to hear what they're doing. So thank you again, and looking forward to it. And please send us any questions you have about the program. I think you're on mute, Monica.
Sorry about that. I said, please drop any questions in the chat during the presentation. And also wanted to just note that this presentation will be recorded so we can actually see the data in real time later. So let's introduce the first fellow, which I believe is Schafer Boeder.
Yeah, that's me. So I'll share my screen. All right. Everybody can see that? Okay.
Great.
Yeah. Thank you. So yeah, thanks for this opportunity. Monica, we really appreciate this chance to speak about our research, and kind of share some of the work that we're doing with the support of the DiabDocs program. And so I'm Schafer Boeder. I'm at the University of California, San Diego. I'm a practicing endocrinologist in diabetes, but my research specifically is clinical in nature. And my interest involves looking at non-insulin adjunctive therapies for type 1 diabetes and how we can use those to address unmet needs in type 1 diabetes, including metabolic and hormonal abnormalities. These are my disclosures. And just by way of background, of course, we have significant unmet needs still in the clinical world of type 1 diabetes. And I'm just going to run through a couple of these right here. One of them being glycemic control. So the vast majority of people living with type 1 diabetes are unable to achieve and maintain glycemic targets. We also have unacceptably high rates of diabetic ketoacidosis, with about 1 in 20 patients admitted each year to the hospital with DKA. And these are examples of 2 issues that are potentially addressable and theoretically addressable with insulin therapy, right? Insulin is our primary and in most cases only therapy that we're using in type 1 diabetes. However, despite improvements in insulins, newer and better insulins, and diabetes technologies like CGM and automated insulin delivery, these problems still persist. We have another group of ongoing issues in type 1 diabetes that include increased risk of cardiovascular disease, where people even that are well controlled from a glycemic standpoint have a 2 to 4-fold risk in developing cardiovascular disease compared to those without diabetes. Insulin resistance is uniformly present in almost everybody with type 1 diabetes. And we think that's largely related to sort of the non-physiologic peripheral way that we give insulin that leads to hyperinsulinemia and induces insulin resistance. Hypoglycemia, of course, is a big problem. 1 in 20 people are admitted either to the ED or admitted to the hospital for severe hypoglycemia every year. And weight is a problem. In adults, about 2/3 of people with type 1 diabetes are overweight or obese. So we have this other group of unmet needs that insulin really can't fix. And in fact, insulin is probably making these problems worse. So to quote my colleague and mentor, Jeremy Pettis, to truly move the needle and improve outcomes in type 1 diabetes, we need to look beyond insulin therapy. So that's what we do. And to talk a little bit about where I've sort of been focused, are these two therapeutic classes. So one is the sodium glucose cotransporter inhibitors, and another is a medication that's a glucagon receptor antagonist, or a GRA. So to tell you why I chose these medications, so we know that the SGLT inhibitors have significant cardiorenal benefits. That's really true across many different populations. Specifically in type 1 diabetes, these medications improve glycemic control and they reduce insulin dosing requirements. But we and others have shown that these medications in type 1 diabetes significantly increase glucagon levels. And that's a problem because higher glucagon not only probably limits the glycemic efficacy of these medications because glucagon will stimulate increased hepatic glucose production, but the glucagon is also pro-ketogenic. And so that may be one of the ways that these medications actually increase the risk of DKA. DKA is sort of the primary barrier for adoption of the SGLT inhibitors in type 1 diabetes. So we're concerned about what the role of glucagon is in DKA with these medications. There we bring in the glucagon receptor antagonist. So volixitamab is a human monoclonal antibody that blocks the effects of glucagon at the receptor. In prior phase 2 trial, we've shown that volixitamab improves glucose control, lowering A1C about 0.5% on average, and at the same time, reducing insulin use by 12%. And because it blocks glucagon's effect, we also have some evidence that it may reduce ketogenesis, or slow the rate of ketogenesis. And we think, therefore, it may help protect against DKA, or at least slow the rate of ketogenesis when in the setting of insulinopenia. So there's a strong rationale to use these medications in combination, which is a little atypical in type 1 diabetes to be adding on multiple non-insulin therapies, but that's what I've been doing. So to kind of show you how I designed a study using these two medications, the SGLT2 inhibitor I used was dapagliflozin at 10 milligrams daily, and then the GRA once a week injection. We enrolled 12 adult participants who came in completing baseline studies. We collected their CGM data and their insulin use at baseline, and then they did what's called an insulin withdrawal test, which I'll show you briefly kind of how that works. And after their baseline studies, they received one of two treatment phases. The first was a combination of both of these medications, the SGLT inhibitor plus the GRA. And the other treatment was the SGLT2 inhibitor alone, in adjunct with insulin, of course, with a placebo. After 4 weeks of treatment, we repeated the baseline studies. They entered a washout period and then crossed over to the other treatment. And then after another 4 weeks, we again repeated those studies. And so ultimately, we're able to kind of compare the outcomes of our studies at baseline, which is insulin only, when they were on the SGLT2 inhibitor alone in adjunct to insulin, and then when they're in the combination therapy with the SGLT2 inhibitor and the glucagon receptor antagonist. So here are some of our outcomes. First, looking at the CGM outcomes. Just to orient you, in black, we have sort of the baseline insulin-only data. In blue, we have the SGLT2 inhibitor, and in green, we have the combination of SGLT2 inhibitor plus GRA. And in these charts, when there are significant p-values, they're shown there, so we can see the comparisons between groups. This is the average glucose. We see that they're a well-controlled group at baseline with an average glucose by CGM of 150. That improved significantly to 138 with SGLT2 inhibitor and improved further to 131 with the combination therapy. We saw sort of similar improvements in the standard glucose standard deviation, as well as the percent time in target range, with starting at 70% time in range, and then increasing to 78 and then 86% with sort of escalating adjunctive therapy. And we were able to achieve this without seeing any increase in time below range. So no increase in hypoglycemia or time below 70. So in terms of CGM outcomes, we found that the combination therapy with the SGLT inhibitor plus the glucagon receptor antagonist was able to reduce average glucose by 19 milligrams per deciliter and increase time in range by 16% without increasing hypoglycemia. We also saw significant decreases in insulin use with the adjunctive therapy. Here we see again the comparison of baseline versus SGLT2 and the combination therapy. We saw similar reductions in the percent of insulin use in the total daily basal and total daily bolus components. And ultimately, the combination therapy reduced total daily insulin use by 27% compared to baseline. this is what the 8-hour insulin withdrawal test looked like. So just very briefly, the participants would come into our research unit. They were all using insulin pumps. None of them were on any long-acting insulin. At time 0, we would remove their insulin pump, basically take their insulin away, and so they'd have no insulin. And we would then, for the next 8 hours, serially measure their blood glucose and the ketone body beta hydroxybutyrate to see how quickly they developed ketone and see how quickly ketogenesis occurred in those patients when they didn't have insulin on board. And then after 8 hours, or if we stopped the study early due to high levels of ketones or symptoms like nausea or vomiting, we gave the participants fluids and insulin and a nice meal and then got them home safely.
Quick question, Schafer,
Yeah,
how much
please.
this is like probably 2 slides back. How much variation is seen in fasting glucagon levels in T1D subjects?
How much variation?
Yeah,
So yeah, from data from our prior studies, so it is quite wide, but everybody with type 1 diabetes has fasting levels that are significantly elevated, at least 10-15% higher than would be expected than baseline controls. So as soon as we kind of start to lose that beta cell to alpha cell crosstalk, we see some elevation in glucagon, and that's true with or without an SGLT2 inhibitor. So everybody with type 1 diabetes has dysregulated glucagon. When we add on the SGLT2 inhibitor, those numbers go up even more significantly, as we saw about 37%. So there is variability, but it is uniform across type 1 that glucagon levels are elevated. And that's true in the fasting setting, but also in the postprandial setting, when really glucagon should be turned off, and instead it gets amplified and sort of further increases hepatic glucose production.
thanks.
Yeah. So this is the 8-hour insulin withdrawal test. Here's some data from that insulin withdrawal test. Again, here we're really trying to induce ketogenesis and sort of, put people in a setting where, let's say their pump fell off or they're traveling and they ran out of insulin. This is kind of what would be happening in their body. And so we measure their serum insulin concentrations. This is just to kind of show what's going on in terms of their circulating insulin. We see that the insulin concentrations do drop off pretty rapidly over the first few hours, as expected. And by the 4-hour mark, right around 240 minutes, the serum insulin concentrations are really at or very near to the lower limit of detection for this assay. When we look at the peak plasma glucose achieved during the insulin withdrawal test, we see that at baseline, people got up to an average of 290. With each of the adjunctive therapies, the peak plasma glucose achieved was much lower, so 178 and 169 respectively. And I just think that's interesting because this is, up to 8 hours with no insulin on board. Certainly these people are going into ketosis. They're making ketones, so the ketone levels are rising. They don't have insulin on board, yet their blood sugars are near normal. So certainly looks like, this is a setting for developing new glycemic DKA, which is of course clinically a concern. And then lastly, from the insulin withdrawal test, we see the peak beta hydroxybutyrate that we achieved during the test. There was a trend for increased levels of beta hydroxybutyrate during the SGLT2 inhibitor therapy. And that trend was reversed with the addition of the GRA. So it does appear that the GRA was able to offset some of the effects of the SGLT inhibitors in terms of rising ketones and the rate of ketogenesis during insulinopenia. So in fact, the beta hydroxybutyrate, the peak beta hydroxybutyrate during the insulin withdrawal test was 17% lower with the combination therapy than it was during the SGLT2 inhibitor testing. So to summarize this study, the combination of the SGLT2 inhibitor and the glucagon blocker reduced average glucose by 19 milligrams per deciliter, or an estimated A1C improvement of around 0.7%. It increased time in range by 16%, which is more than 3.8 hours per day in range. And it reduced total daily insulin use by 27% compared to the baseline. And when we compared it to the SGLT2 inhibitor treatment phase, we were able to reduce peak beta hydroxybutyrate during insulin withdrawal by 17%. So we found that this therapeutic combination has potential to improve glycemic control and reduce insulin use, while hopefully mitigating ketogenesis in this population. And then very briefly, just sort of our next steps, what we have planned and what the DiabDocs program has sort of supported is building this out. So to build on that study, I planned another double-blind placebo-controlled crossover trial using this therapeutic combination, comparing it against placebo in adults with type 1 diabetes. This is a larger study with N of 24 and much increased treatment duration. So each treatment phase will be 12 weeks, and there'll be a 14-week washout period in between treatments. The outcome measures, some will be similar, and then we'll have additional outcome measures. So we'll again be looking at glycemic control, including A1C and the CGM metrics. We'll be looking at ketosis and ketogenesis using ambulatory ketone measurements, so home ketones, as well as the insulin withdrawal tests. We'll be measuring participant-reported outcomes like treatment satisfaction and diabetes distress to see how these different treatments are actually affecting people and their perceived well-being. And then we're also adding some additional aims, really focusing on how the adjunctive medications are affecting hyperinsulinemia, and then measuring things like insulin sensitivity and insulin clearance using the hyperinsulinic euglycemic clamps. Because ultimately, we want to know if reducing the insulin doses using these medications can actually improve hyperinsulinemia and can help reduce insulin resistance that we see in type 1 diabetes. So just super quick thanks to my lab, the Clinical Diabetes Research Group here at UC San Diego, and a huge thanks to the DiabDocs program and to the JDRF who have supported my work. So that's it for me. Thank you.
Very nice. Thank you very much for the report from San Diego. It's very promising, and it looks, that these are some huge problems in, managing diabetes, and it's great that you're tackling them. Is there any other questions from the audience? Feel free to drop one in the chat. All right, next up then, Dr. Chen.
So hi everyone, my name is Charlotte Chen. I'm one of the pediatric endocrinologists from Children's Hospital at Montefiore. I'm very excited to be here. My research talk title is Overcoming Barriers and Reducing Disparities in the Use of Advanced Diabetes Technology in Youth with Type 1 Diabetes. I do not have any financial disclosure. So several studies have shown that Black and Latino youth with type 1 diabetes are twice as likely to experience adverse health outcome. And it's known that diabetes devices can reduce acute diabetes complications and improve health outcome, and is a potential mechanism to reduce inequality in outcome. From a study in 2015 done by Willie et al., Black and Latino youth are less likely as white youth to use diabetes devices, regardless of income or insurance. So you can see in this graph here that the non-Hispanic white had the highest pump use across all age group. And despite the rapid advancement in diabetes technology, recent data from the Type 1 exchange continue to show similar trend.
I had a quick question,
Yeah.
just to sort of like set the stage. What % of type 1 diabetes are non-Hispanic white, non-Hispanic Black, and Hispanic?
That's a great question. I don't have that exact information, but I'll get back to you.
Oh yeah, sure.
Yeah.
I just was kind of thinking about like the opportunity.
Yeah, definitely the incidence is increasing. And the search data has shown that, but the exact percentage, I don't have it exactly. Thank you.
I think it was 71% non-Hispanic white, but don't quote me. So, all right, thank you. I don't know the other, distributions, but it's definitely an opportunity. Alrighty.
All right. So there's ample of data to suggest that multiple level barriers, aside from financial, that prevents youth with type 1 getting started or staying on technology. For example, social determinant of health, which are non-medical factors that influence health outcome, may interfere with diabetes technology use. And these factors shown here, such as housing, education, utility, transportation, childcare, legal, food, access to medical care, and support system. Therefore, my hypothesis is that co-addressing unmet social and type 1 diabetes technology need will improve diabetes technology uptake and use in youth with type 1 diabetes. So my research objective is to explore the care needs and challenges and co-create solutions for diabetes device use for Black Latino youth with type 1 diabetes by incorporating feedbacks from youth, families, providers, and school-based healthcare providers at the Children's Hospital at Montefiore. Just to give a little background, the Children's Hospital at Montefiore is an urban safety net hospital in the Bronx and takes care of youth from one of the poorest congressional districts in the country. In addition, Children's Hospital at Montefiore also has a school-based health center where they have medical providers such as MD and NP on site at school. So using human-centered design methodology, which is a creative and collaborative process that puts really people at the center of the design process. We elicited multi-stakeholder collaborative input. And during these 2-hour workshop, we really encourage collaboration and active thinking. We explore each step of the diabetes tech journey framework, which has been developed and published by Dr. Shabani Agarwal, my primary mentor. And so, as you can see, the diabetes tech journey in this slide here, you have the learning about and deciding to get on tech and getting and starting the tech and managing problems and situation with the tech. And the participant also co-created a solution of the barrier mentioned about the diabetes tech journey. So far, we've completed around 17 human-centered design workshop, and we have like 15 parents of 2 to 12-year-old, 4 parents of 13 to 17-year-old, and 14 youth of 13 to 70-year-old, 4 Spanish-speaking parents, and as well as 12 providers at CHAM, which included medical providers, social work, psychologists, and 6 school-based medical provider from the Montefiore school-based program. Here, I just want to share some preliminary quotes from the transcript today before we do more intensive analysis. And so when we asked parents about the process of learning, deciding to get on technology, the parent said, I just stopped using the Dexcom, and I actually didn't have a glucose monitor for over a year until I heard about the Freestyle Libre, which the doctor did not want to okay it. And this may point towards potential provider bias, and we'll see if it's an emerging theme. And when we discuss about getting and starting using a tech, one parent expressed financial concern, especially the burden of copay to start the device. So that parent said, I YouTubed it instead of paying out of pocket to go see somebody train when you can do it on the video. When we talked about managing problems and situation with tech, parents also discuss a lack of support, especially from school. And here are some quotes. I had to take care of her all the time. I don't know, something sticky with me because I cannot go anywhere and I cannot do anything. I got to work at home. I'll go to one school and they'll tell me that they have a nurse. And when I said that she is diabetic type 1, they told me that they don't have a nurse this year. Another parent said she has to be picked up, miss school because the technology failed. And also I have to leave work early because of that. Like, that was unfortunate and it was unfair. And another parent said, we had a tough time for anything the nurse, and that she meant the school nurse would call, if there's no data, and it was just out of control. So our next step is to evaluate the feasibility and acceptability and device use of a tailored community health worker program in a 6-month pilot study of 10 to 15 device non-users. And we will be able to tailor the community health worker program using information obtained from the human-centered design workshop so that it could better support child, family, and community needs for the unrepresented youth with type 1 as they relate to diabetes device uptake and use. And just a brief background, a community health worker is a person from the community of interest who can connect people to the resources. And they can also do like social needs, care coordination, and advocacy. So the hypothesis for our next step is that the enhanced CHW intervention will be feasible and acceptable in the youth with type 1 and their families, and the device uptake will increase. Thank you. And I just want to say thank you to my mentors and the DiabDoc program.
Thank you very much. That was really interesting, and definitely some work needs to be done, and thank you for doing that. And next up, Jamie Felton. Dr. Felton?
Okay. You all
Perfect.
see the black slide?
Yes, it looks great.
Perfect. Okay, great. Well, thank you very much for this opportunity. I'm really excited to talk about some of the work that I've been doing that's been funded and really supported by the DiabDocs program. So it's been fun to hear updates from others as well. But my name is Jamie Felton. I'm a pediatric endocrinologist at Indiana University. And my primary research interest is really understanding the immune pathogenesis of type 1 diabetes. And so what I'm going to talk about today is my DiabDocs focused project that looks into specifically type 1 interferons and B cell metabolism as drivers and potential targets for treatment. And so if you ask anybody, any pediatric endocrinologist or adult endocrinologist or researcher, they will probably tell you that especially the last year has been really an exciting time to be in the field of diabetes research. And that in large part is due to the FDA's approval of teplizumab about a year ago. Teplizumab is an anti-CD3 antibody, so it's an immune therapy that was shown to delay onset of type 1 diabetes. In people at risk. And immune therapy is not something that has, it's been something we've been trying to do for a very, very long time, really since the 1980s. And so the fact that we now have something approved really is exciting and is a tribute to hard work from years and years and years of research. And so leading up to that approval, Jeff Bluestone, Jane Buckner, and Kevin Harold published in a special issue of Science a review that talked about the state of immunotherapy in type 1 diabetes. And they described immunotherapy for type 1 diabetes as being at an inflection point. And there were 4 points that they brought up. One, that current therapies can slow disease progression, and many of them that are not FDA approved and have been in trials have been shown to slow disease progression, but not do anything long term. Now we have one that can delay onset. But immune tolerance and independence from insulin are still elusive. That's a goal we haven't achieved. Broad depletion therapies, when we think about taking away large populations of B cells and T cells, are really limited by risks of immune suppression. And then maybe the most important, or the one that rang truest for me, was that targeted therapies require an understanding of disease pathogenesis. And so my long-term goal is to, like I said before, understand the immune pathogenesis so that we can develop effective and safe therapeutic interventions. And so I'm going to talk about the one that I'm focused on for this DiabDocs program. We know that autoantibodies are the earliest biomarker of type 1 diabetes disease progression to date. And this is some seminal work that really showed that if you have 2 or 3 islet autoantibodies, your likelihood of developing type 1 diabetes is nearly 100% over the next 20 years. And so that has really changed the way that we look and consider type 1 diabetes. And if we look at this framework taken from TrialNet for type 1 diabetes progression, we know that individuals with genetic risk have some sort of immune activation that's not completely understood that leads to the production of those antibodies. And so you can see that having antibodies but normal glucose tolerance is now stage 1 type 1 diabetes. If you have abnormal glucose tolerance, it's stage 2, and stage 3 is what we classically consider new onset type 1 diabetes. And so I think the important thing to notice here is that autoantibodies are the earliest biomarker that we have of type 1 diabetes. And because of that, virtually all of our trials have been in these stages, stage 1, stage 2, stage 3. But importantly, the immune activation has happened long before that. And so while antibodies are an early biomarker, I think it's important to know and to understand that the fact that we can detect them in the blood indicate that critical interactions between autoreactive T cells and B cells have already occurred. And so the purpose of this slide is not to understand all that's happening here, but mostly to illustrate that you have a naive B cell, a B cell that hasn't been exposed to any antigen, foreign or self, is exposed to self-antigen, has to be activated and go through many, many different steps to eventually become a cell that's going to secrete antibody. And so while autoantibodies are our earliest biomarker, there's lots going on before that. And so my interest has really, I've developed an interest in what is happening before the development of autoantibodies, before seroconversion. And my hope is that by understanding what's happening there may be something that we can target to give us even more time or longer prevention. And so when we ask a research question, we always look and see what is known. So what do we know already about what happens prior to seroconversion, prior to the development of autoantibodies? And there's some really interesting work that published back in 2014 that looked at peripheral blood samples from individuals before and after they developed islet autoantibodies. And what they identified was this type 1 interferon signature. And type 1 interferon is an inflammatory cytokine. We usually see it produced in association with viral responses, but they found this gene signature that could be detected in individuals that was higher before they developed autoantibodies compared to after they developed autoantibodies. And so you can see that here, before autoantibodies and then after, and then SC stands for seroconversion. So before seroconversion and after seroconversion. So there's this increase in this type 1 interferon signature. At the same time, some really great work from Mia Smith and John Cambier's lab has shown that there is a population of B cells that are circulating that in people without autoimmunity are typically circulating in this anergic state, meaning they're there. People, even without autoimmunity, have B cells that might recognize self, but they're not dangerous. They're not going to do anything because they are in this anergic or unresponsive state. And what they found was that prior to type 1 diabetes, that population disappears in individuals that are going to develop type 1. And so the things that are going on before type 1 diabetes as you are developing autoantibodies are these changes, this type 1 interferon signature, in addition to a change in this B cell developmental subset. And then finally, there's work from other immune cells, specifically the one from published in Immunity here is talking about macrophages, but there is data to link type 1 interferons to changes in cell metabolism. And so knowing that type 1 interferon signatures precedes T cell activation in individuals with type 1 diabetes, and that loss of B cell anergy also precedes that, our hypothesis became that type 1 interferons alter B cell metabolic programming to permit this escape from tolerance and this loss of tolerance. And so my project here is really understanding the interaction between type 1 interferons and B cell metabolism to see if that is true, and then specifically ways that we could target it to change that progression. And so to approach this, we're using both mouse and human models. And the first question we want to answer is what happens when autoreactive B cells or B cells in mice that are prone to develop type 1 diabetes, what happens to their cell metabolism when they're exposed to type 1 interferon treatment. And interferon alpha is one of the main type 1 interferons. And so we treated black 6 mice. So on the left of the slide are mice that are control mice. They are not going to develop type 1 diabetes. Compared to NOD mice, which is the non-obese diabetic model, which is a mouse that will spontaneously develop diabetes. If you just let it go about 18 to 20 weeks, it will develop diabetes. And when we looked at oxygen consumption rate, which is a way to measure the pathways, the energy pathways that are being used in these cells, we found that in the black 6 mice, there really wasn't a significant difference when they were treated with type 1 or interferon alpha. Compared to the NOD mice, where we saw a significant decrease in oxygen consumption rate, which speaks more to some of the glycolytic pathways downstream. But I think the important take-home point here is that there is this metabolic difference in these mice that are going to develop diabetes in response to type 1 interferons. And so we also asked the same question, but asked what are type 1 interferons doing with B cell development and how B cells are developing. And when we treat B cells from diabetes-prone mice compared to control mice with type 1 interferon, we see that the B cell population is skewed towards this marginal zone population. And so that's what you can see here. What's really interesting is that some of the work I was able to do in fellowship looked more specifically in a mouse model that allowed the study of insulin-specific or antigen-specific autoreactive B cells. And what we saw there was that those antigen-specific autoreactive B cells accumulate in that marginal zone. And so this data does not show that you have more antigen-specific cells. That would be an experiment that we still need to do. But the fact that that population increases, I think is really intriguing. And at the same time, when we look at an activation marker, just a B cell activation marker, what we see is that we have slightly more activation as measured by CD69. And you can see because that peak is moved a little bit further to the right in the NOD mice compared to the black 6 mice who will not develop diabetes. And so from this slide, the conclusion is type 1 interferons are altering how B cells are developing. And so we're kind of bringing together the B cell metabolism and the B cell development in those early stages. We also obviously were using the mouse models to work to look and understand human disease. And so as part of this DiabDocs program, I also have some aims looking at human samples. In anticipation of those are currently in progress, and we are working on those as we speak. But to prepare and to kind of help lead the way, we've also looked at some publicly available data from a longitudinal cohort from Europe that followed individuals starting at 3 months up to 36 months, and they were genetically at risk, and followed them to see when they developed autoantibodies or when they developed diabetes. And so the first step in this analysis has been to look at cases of people that did develop diabetes by 36 months versus not. And then we're going back to look at those time points before to see if there are differentially expressed genes or transcripts. And so this is preliminary analysis, but just to show that they are definitely distinctive. And you can see it at 6 months here, immediately prior to often disease development here, there are differentially expressed genes. And so we are working with, I have a bioinformatics person on my mentor team who's been really helpful into digging into what those genes are, and really evaluating whether we can see specific things about metabolic pathways and B cell developmental pathways. And so really, what does this matter? Why are we concerned, and what will happen if we can understand this? And I think this thought of targeting immunometabolism to change as a therapeutic intervention or to change outcomes is something that also is not new. It is being used and actively pursued in cancer immunology. And then this review was published in 2020 that looked at basically targeting immunometabolism as an anti-inflammatory strategy. And none of the examples in this review included type 1 diabetes, and they were focused primarily on T cells and macrophages. But the thought, I think, is one that is applicable, and given a better understanding of really what is happening early in disease progression, the potential to use a small molecule to alter or skew the development of an immune cell, or B cell in this case, towards an anti-inflammatory versus pro-inflammatory phenotype is really possible. And so I think the overall goal is to understand this interaction between type 1 interferons, B cell metabolism, and how it leads to a loss of tolerance, so that we can intervene and change that.
Quick question from the audience, if
Yeah.
you take it. Interferon alpha is an innate immunity cytokine that is universal. In your theory, what could trigger the increased interferon alpha in the early stage of T1D? Thanks.
Yeah, that's a great question, and a question that is more difficult to answer. And one of my immunology mentors, because I am interested in that as well, suggested maybe not addressing that one right away, because I think that is a very difficult question. I think just thinking about it, and we think about environmental triggers, and often those are viruses. And so type 1 interferon is this innate inflammatory cytokine that we see produced in response to viruses. And so is there some sort of viral trigger that leads to that change? I think that's possible. That's a hypothesis. I don't know that for sure. Beyond that, I don't know, but it's something that I've been thinking about. And it would be great to have more people thinking about it.
Yeah, it's great to open that discussion.
Yeah. I think so. This is my last slide. I have lots of acknowledgments. I have amazing mentors. Carmela Evans Molina and Mark Kaplan are my primary mentors for this project, and lots of people that have gone before. And Nick Jonas is my favorite celebrity with type 1 diabetes, so he gets a spot there too. But that's all I
Yeah,
got.
he's done a great job getting the word out. Thank you very much, Jamie. That was really excellent. And kudos for really diving into the etiology headfirst and really pulling out some great data. So I cannot wait to see what comes next. It's very exciting. And sort of last but not least, if Dr. Quandt, Zoe Quandt, could put up her slides.
Thanks so much for having us. I think I want to just start very quickly by highlighting one of my favorite parts of this K-12 program, which is getting to meet colleagues who are doing such a diversity of research across the country, but are, in similar stages of life. So it's been a wonderful group to be able to be part of. I'm going to talk today a little bit about immune checkpoint inhibitor induced diabetes, which I think will be interesting, especially coming off of Jamie's thoughts about tolerance. So immune checkpoints and their inhibitors alter the immune set point in our bodies. So we have these drugs. There's over 7 drugs now that treat over 20 cancers. And they've really revolutionized cancer therapy over the last 10 plus years. They take the set checkpoints that are supposed to decrease or attenuate our immune responses and release them so that our immune system basically is allowed to become activated. These are all of the cancers that they're approved for at this point. One of the most exciting is that any solid tumor that is MSI high. So that's the first actual FDA approval that's tumor agnostic. And again, basically what they're doing is taking a mechanism that's supposed to be decreasing autoimmunity in our body and turning it on so that we fight cancer, but we see these autoimmune side effects. And this is really just kind of changing that tolerance set point that Jamie was mentioning. These benefits have this cost, these immune-related adverse events. Within the endocrine system, thyroid dysfunction is far more common than all of the others that we see, but we do get an insulin-dependent diabetes that clinically is treated like type 1 diabetes. But our question is really why this happens and if it is truly the same disease as type 1 diabetes, or should we be thinking about this as something different from a mechanistic point of view? It's quite rare. We don't really have a good idea, or as this research started, we didn't really have a good idea of why it happened in some people and not others. But it also offers this opportunity where we have a very contained point where we are altering the immune system. And so we can kind of think about this as before. These patients are cancer patients, for the most part. They're older adults that have lived their whole lives without developing type 1 diabetes, and they have this alteration in their immune system and then develop diabetes. So we think of it really as an opportunity to study a provoked beta cell autoimmunity. I'm taking a multi-pronged approach to understanding this through the K-12 program. The first thing we're looking at is the analysis of genetic risk, and then looking more into autoantibody discovery and what we might be able to learn by looking at the actual cellular phenotypes in patients, pancreas and blood. So I've had the opportunity to work with the Parker Institute for Cancer Immunotherapy, who have done a longitudinal study of over 1,000 patients that get started on immune checkpoint inhibitors, and we've watched for immune-related adverse events to occur over time. Only about 500 of these 1,000 patients have no evidence of diabetes, either as a comorbidity or any sort of diabetes medication. So we're going to use that as our control group. Out of the 1,000 people, only 3 developed checkpoint diabetes. And so I've also looked at it within a UCSF and Yale cohort that we've published before, and then relative to Caucasian type 1 diabetics. And what you can see here, again, we have pretty small sample sizes. So as our cohorts grow, we might see some significance in other places, but there really is a predominance of these DR4 positive, these are HLA types. So the strongest part of the genetic risk for type 1 diabetes is held in the HLA region. And there's really 2 haplotypes, DR4DQ8 and DR3DQ2, that carry the most risk, although there's others that carry some risk. And then there's one that's quite protective. So DQ0602 is a very protective HLA type to have. And so what we've seen looking at our cases as well as the Radiohead cohort through the Parker Institute is that we see this overrepresentation of DR4 in patients that develop checkpoint inhibitor diabetes, even above those Caucasian people that have type 1 diabetes. And we can see that the rates of the other HLA types are much more similar in the UCSF cohorts to patients with type 1 diabetes compared to our control patients. But again, perhaps this is something we'll see actually emerge as significant as time goes on. The other thing that's really interesting that we're seeing is a very similar protection benefit from the presence of DQ0602. It's not complete. We do have some patients that develop, since this case series was published, that have developed type 1 diabetes, or sorry, checkpoint diabetes with DQ0602, which is similar to patients that develop type 1 diabetes. You can have that, it's just much less common. And so this is kind of a starting off point for us to think a little bit more about the genetic risk. And so what we've started to do is compare patients' polygenic risk score in checkpoint diabetes relative to type 1 diabetes. And so we have these very well established genetic risk scores. There's a GRS1 and then more recently a GRS2, but basically these risk scores extend on that HLA risk disposition, adding a lot more genes. So the more recent one has 67 single nucleotide polymorphisms that it uses. And we're working on basically comparing our checkpoint inhibitor patients, treated patients, to those with conventional type 1 diabetes and trying to determine if that PRS looks more similar or less similar, which will give us a sense of whether the rest of those genes might matter for these patients without actually having the sample size, since this is such a rare disease, to do a primary PRS or GWAS study. One of the other things that we noticed early on is that the autoantibody prevalence in patients that have checkpoint inhibitor diabetes is much lower than what we see in patients with conventional type 1 diabetes. So in conventional type 1 diabetes, as Jamie just showed us, almost everyone will have antibody, at least one antibody at diagnosis if all 4 antibodies are checked. And in our patients, it's about half of the patients. At this cohort, it was 40%, but somewhere less than 50% will actually have autoantibodies at diagnosis. So that's in pretty stark contrast to what we typically see with type 1 diabetes. And this has led us to a new approach of looking for novel autoantibodies. We're using a phage display technology championed by Joe DeRisi at UCSF that basically takes 49 amino acid sequences across the whole genome to look for novel autoantibodies. And so that analysis is underway. And then finally, we've had a really exciting opportunity to actually look at the cells within a pancreas of a patient who developed checkpoint inhibitor diabetes. So he's a 68-year-old man. He had no prior medical history, no family history of diabetes or autoimmune disease. He developed stage 4 melanoma. He got treated initially with Ipi and Nivo, so combination CTLA-4 and PD-1 inhibition, and he developed hypophysitis, so pituitary inflammation. He actually had a really good response at that point, and so once he gets started on hormone replacement, he gets started on nivolumab therapy again. He has no evidence of disease. At 15 months, they decide to stop treatment, and he comes in a couple of weeks later with a glucose of 595, an A1C of 9.2. He gets started on insulin. He, like many of our patients, does have any autoantibodies at diagnosis, and then unlike the majority of our patients, also did not have a high-risk HLA type. He goes on about his business. He got surveillance scans, no evidence of disease, no evidence of disease. And then all of a sudden they pick up that he has a pancreatic adenocarcinoma on one of these surveillance PETs. So he undergoes conventional chemotherapy and then goes for a Whipple procedure, at which point we're able to get a sample collection for histology, advanced imaging through Codex. We also got tumor, and so pancreatic tumor and PBMC at that point. And so we've used this opportunity to really interrogate what the actual tissue looks like. The first thing that we note on basic H&E is that we see the islet cells. There are very few islet cells left. But there is this immune infiltrate around the islet cell. It is both CD3, as we can see here, so T cell and B cell predominant. There really is no insulin production in this islet, so there's really no beta cells left, but we do see some glucagon production still. We were able to, from some colleagues, get access to what the type 1 diabetes pancreas looks like from NPOD data, and we can see some very similar sorts of appearances in some of the patients that samples that they have. Some of them still making insulin, and then some of them more like our patient where that insulin production is gone. We've had the chance to look with more advanced imaging mechanisms like Codex, which is able to stain for multiple different things. And just again, this is looking at the immune landscape across the sample that we have. In the dark blue, you can see the scattered islets. In the red, you can see CD8 T cells. And in these cyan colors, you can see these T and B cell clusters that were very interesting to us. I'm sorry, there's some things. We've looked at this with single cell sequencing. Again, I think one of the things that was very surprising to us here was the predominance of B cells, despite this patient actually not having any autoantibodies at diagnosis or at subsequent follow-up. And then maybe less surprising to us, the CD4 and CD8 T cell populations. We're looking at all of this in more detail, but kind of high level considering the time that we're looking.
Quick question for you, Zoe. A question from Jamie Felton. Are the T and B cell clusters possibly infiltrated islets?
Yeah, so that's kind of our theory, is that they're actually kind of a TL, we're like not wanting to use the word, but a TLO that kind of were formerly islets and now like just a residual left behind island. So that's our hypothesis, definitely. It is a little hard because he had pancreatic cancer, and you can see these types of populations. And this was not tumor, but it's a little hard to differentiate because of that new cancer that he has. So we've also compared T cell receptors within this patient, looking at what's shared across compartments as well as what's what's expanded within each compartment, and then compared them to type 1 diabetes TCR databases. And this is probably a little bit small to look at, but this is a more detailed UMAP of the different populations. And really what I wanted to highlight here is that the expanded and shared cells are predominantly found in the CD8 T effector memory cell population, and are less present in other areas. And that we do have some matching with type 1 diabetes TCR databases. We aren't sure if there's any antigen specificity for these TCRs at this point, but it's a kind of exciting next step for us to look at. And then we'll be looking at this in the peripheral blood from our much larger cohort, kind of using these as anchors from the one patient where we actually have pancreatic tissue. I have a huge team of people that have helped me with many aspects of this project, and some that I didn't even talk about today. So I've highlighted all of them here and the different funding sources that have supported me over the last few years.
Thank you so much. This is really exciting to see what this first cohort has achieved. And really kudos, Peter Moss had to, Dave Moss had to jump off, but just amazing what he and you, Linda, have accomplished in setting this up and really getting it off the ground. It's really an exciting team, and you've got the 4 first fellows here, or I guess recipients, and then you've got 7 coming on their heels. So there's more work to be talked about and shared, and we really look forward to doing that. Is there anything else you'd like to say or share regarding?
No, I just want to say that we're incredibly proud of all of our scholars, and I'm just so impressed with the 4 of you and what you did and the work you're doing. And it is a lot of fun to see the diversity in areas and just the camaraderie across the group. So no, we really appreciate the invitation to have everybody present here and highlight the program and the great work that our group is doing. So we
Yeah.
appreciate it.
It's really great. Oh, one last question before we hop off. Zoe, from your data, would you think the CPI-DM is similar or different from the typical T1D pathogenesis? Thank you.
I feel like I'm still as split as I was a few years ago. I mean, I think there's a lot of things that are shared, but there are some distinct things. I didn't really get into this, but what we do see is that there's some patients that develop checkpoint inhibitor diabetes right after starting therapy, like within the first few cycles, and there's others where it's a year later. I think that those people that develop this very early, they're more likely to be autoantibody positive at diagnosis. I suspect when we get into the PRS scores that they're going to have higher PRSs, and that this is just like the straw that broke the camel's back. Like this patient was barely holding on to, they were kind of like on the brink of developing LADA or type 1, and then they get checkpoint inhibitors, and that fully they can't tolerate it anymore. And then this second group that's often the later onset that are more often negative for autoantibodies, I suspect might actually be a very different mechanistic disease. So that's the other thing I keep in mind as I go through all of these patients.
Thanks for answering. All right. Well, in the interest of time, thank you all again. It's great to see the interdisciplinary viewpoints and pursuits, and I think it's fantastic that you're all communicating and, providing sort of like cross-fertilizing each other's ideas. Amazing group. Thank you again, and I hope you have a great rest of the day. We'll follow up with you in the future as well.
Thanks, Monica. We appreciate it.
Bye-bye.